Yes.
Yes.
So this is the guidelines that we are talking about, and these guidelines are, of course, given, but the clinical judgment of the physician also has to be used in this, and it should prevail. And that is why at various points many things have been left to the surgeon's discretion, because the ophthalmology is not going to change in the COVID era. It is only the way we practice, the way we do ophthalmic practice, that is possibly going to change. So we had 225 plus experts from different fields with 20 plus Zoom hours and 13 plus societies who contributed to these guidelines. And we are actually very grateful to them for sparing their time and doing it in such a short span of time. These are the various Zoom meetings that we had. And for some of the specialties, we had to have more than 2 meetings. And these are the societies that were involved. So we tried to cover all the societies, especially the sub-specialty societies, as well as had representation from Ministry of Health and Family Welfare, Vision 2020, and NPCB. These have, of course, been divided into various types of practice, and I will be talking to you about the phaco practice. It is important to take a declaration from the patient when you screen, and also important to take a ophthalmic treatment, ophthalmic procedure, or ophthalmic surgery consent form. So this has already been incorporated into these guidelines. Dr. Pramila Gupta sent this order at 8th May in 2020, where distancing was advised at 6 feet, and then later on it was changed to 1 to 2 meters. And we are thankful to her for that. And basically, like Dr. Mahipal also emphasized, that further updates will be available because these are dynamic guidelines. Now, when the patient comes to you pre-operatively, you have to decrease the amount of the patient, the time the patient spends in the clinic, the number of visits, the minimum number of staff needed to function, and delineate areas based on the uh, patient flow. Physical distancing is important. Prior appointment should be taken. Only one attendant. Arogya Setu has been emphasized by both Dr. Mahipal and Dr. Lalit Verma. And of course, the history of talk and a separate triage area is required. Then temperature is required in the preoperative visit, and payments should be online preferably, and need for multiple stations may be required based on the number of patients which are seen. Now this has been talked about: the mask, reducing the workforce patient contact time, avoiding or minimizing re-examination of the patients who have already been assessed, cleaning all the surface, sanitization, keeping safe distance, and avoiding or minimal talking at the slit lamp should be done. Then the patient also should be advised that he should not get baggage, and sanitization has to be done, and it should be seated in the designated seats only. Now, as far as the refraction is concerned, one can start with the lowest achievable line to speed up things, and you can ask the patient to close his eye with his own hand rather than with the occluder. And of course, history should be taken, maintaining all the social distancing. There is a protocol which is given for trial frame, pinhole occluder, lenses, etc., and should be sanitized in the proper manner. Intraocular pressure can be taken with the Goldman applanation tonometry, and Glaucoma Society of India has given very robust guidelines on how one should take intraocular pressure of do field examination if required. And lacrimal sac evaluation should be done taking universal precautions, and in suspicious cases of chronic NLD obstruction or chronic dacryocystitis, it is advisable to postpone the cataract surgery. Again, the Oculoplasty Association of India has given very robust guidelines, which have also gone into publication on how to do the oculoplasty examination. Distant direct ophthalmoscopy should not be used. Indirect ophthalmoscopy may be done, and if required, neodymium capsulotomy can be considered whenever necessary with a breath shield. Now, there are various methods which have been described for the dilatation. One is that you can ask the patient to dilate from home only and come, especially if it is one day before the surgery. And after you've done the investigations, always you have to repeat the whole thing. That is, take history, do thermal scan, etc. Because in between the investigations and the date of the surgery, the patient, if he has come in contact with the COVID patients, then again it becomes necessary to rule out this. And if you don't want to touch the patient, then you can use a bud, or you can use a swab stick to pull the lower lid down with the help of the disposable gloves. Now, when the patient enters the operation theater, he has to be allowed, after wearing the mask covering the nose and the mouth, Sanitization is important. A patient and technician both should sanitize instruments with the headrest to be attached with the breath shield. Ultrasound biometry, when it has to be done, the tip of the probe should be cleaned with the alcohol swab after every case, and sufficient time should be given to dry it. In case of immersion scan, it is again advisable to clean it, and the Pragar shell along with the probe can be cleaned with the isopropyl alcohol. Then again, if you're doing keratometry, a breath shield should be there in between, and a joystick. All the parts of the instrument should be again cleaned with the alcohol swab. Then when you're doing optical biometry, again, that has to be cleaned with a lint-free cloth dampened with alcohol, 70% isopropyl alcohol. And some of the biometers would also have the manufacturer's guidelines as to how to clean it, and those can also be followed. And again, breath shields will always be incorporated in all instruments where the patient sits, and you have to examine the patient. Counseling is important to give clear instructions, and the patient should not be allowed to mingle with other patients when the patient is counseled for surgery, and special COVID consents have to be taken before surgery. Now, this is important. This is something coined by Dr. Jagdish Reddy, who was majorly helpful in making these guidelines. Assurance, clinical, administrative, and legislative or ACAL, which is the acronym for this, preparedness for opening the OT. So one is you have to make the public aware about it and assure the public that all safety measures will be taken for elective consultation and surgery. Then clinically, you have to check for availability of the PPE, check for the availability of the backlog, reorient with the cleaning protocols which have to be followed preoperatively in the anesthesia room, patient waiting rooms, OTs, and changing rooms. Monitor the risk profile zones, and utilize the utilization of the OT and efficiency of the staff have to go hand in hand for economic considerations also. And OT schedules may need to be staggered over a period of time, and you may have to work for prolonged periods of time, prolonged hours, and also perhaps at the weekends to improve the efficiency. Then logistics are important because some of the consultation may be done by teleconsultation. So if you're not into it, you may consider thinking about it. For the staff, it is very important to train them. Mock drills need to be done so that they are acquainted with the new protocols, which then become the part of the system. Then assess the inventory and ensure a constant supply of it. Ensure that all your equipment is working. And in the absence of any definite evidence for the need to change the operating environment for cataract surgeries, the current OT facility may continue till definitive guidelines are issued by Government of India. So when the patient comes in, you have to triage the patient, and the patient should change into OT clothes before entering the OT, and both the patient and the attendant should be wearing the mask. One should ensure that there's safe distancing, and one has to space out the OT. This has very much been talked about as to what has to be given in the operation theater. And anesthesia, preferably topical anesthesia, has to be done. Block anesthesia may be done as appropriate, and one can instill topical anesthetic drop. 5% povidone iodine is supposed to be virucidal, so that should be applied. And care should be taken to prevent spillage of the body fluid on the surgeon, anesthetist, staff, or the floor. And if number of patients is limited, then the retrobulbar or pelibulbar anesthesia may be given directly on the OT. Now, there's always a question as to whether this surgery phacoemulsification is aerosol generating or not. And as per the personal communication from Dr. James Shadush, it is not aerosol generating, for the simple reason that you are using povidone iodine before the surgery. The aqueous then gets replaced by the viscoelastic agent, and then subsequently by the BSS. So again, this was highlighted in the OT protocol guidelines. Apply sterile drapes. There should be no leakage. The pouch should not be leaking, and it should be appropriately draining the fluid. Viscoelastic to be used frequently on the cornea to avoid need for frequent installation of the BSS or ringer lactate. Handle the equipment carefully to avoid any injury, and the assistant team should handle patient with gloved hands, mask, and linen gown. Again, minimize the number of people who are there in the operation theater. Sterilized phacoemulsification tip and sleeve can be used for each case. Uh, Avoid delivering ultrasound energy when phacoprobe is not in the anterior chamber, and all sheets on the OT should be changed in between the patients, and the tables should be sanitized using appropriate disinfectants, and the disposable instruments should be discarded using the biomedical waste policy. Now, the post-operative care and follow-up is customized on a case-to-case basis at the surgeon's discretion, and post-op visits may be limited and only when required may be done. Of course, when the patient again comes back for a follow-up, same protocol has to be followed as for the outpatient department, and encourage teleconsultation. So these are the references from where these was made, and these were the expert groups from the various societies and also from the various institutions who helped in this, and we would like to acknowledge their efforts in the last 15-20 days for numerous meetings for which were held, and all these people have helped in making these guidelines for the various surgeries which are now available to you on your laptop for you to refer. Of course, these are dynamic guidelines and these will keep changing. And we are grateful to the entire governing council of AIOS for doing it, Dr. Mahipal Sachdev for spearheading it, and everybody in the governing council who was a part of this document, and all the managing committee members also who gave their inputs. And of course, Dr. Lalit rightfully said that these are the unsung heroes whom we never talk about. They have been working day and night to make this happen and to get it as fast as possible. So thank you very much for your kind attention.